I'm so excited to have on the podcast today Dr. Ceri Cashell, who is a GP who has a passion and focus on hormones and menopause. So thank you so much for being with us.
Thank you very much for having me.
So, Ceri, tell me about when you started getting into this area of medicine, because you weren't always in the hormone and menopause space, were you?
No, so being a female GP, you do tend to have a much bigger patient base that is women, and women of all ages and girls. But it was about 3 years ago that a patient came to see me who had been started on testosterone by another doctor, and she had felt it was such a game changer for how she felt. She wanted to spread the word, and as I was her usual GP, she said, I think you really need to go and learn about this because it could be a game changer for other women. And there's a course in the UK run by Dr Louise Newson, who is really one of the leading voices in menopause care. And she said, go and do that course and see what it does. And that really was. So it took me a couple of months, but I did go and do the course and then listened to all of the podcasts by Louise Newson. And it was really, quite mind blowing to suddenly view medicine, especially female health, through this new lens of hormonal health, and a lot of things that had really probably been slightly mysterious before suddenly all made sense. So it's really understanding the whole life cycle of the female from puberty right through to the grave, and seeing how ovarian hormones impact everything, at such a significant level, as well as learning that testosterone is in fact a female hormone. In fact, it's our most abundant hormone of the three. We make our good estrogen or estradiol. It's made from testosterone in the ovaries up until the point of menopause. After menopause, your ovaries don't manage to convert it to estrogen anymore. So women, both before and after menopause, their highest level of hormone is actually testosterone. So, so after menopause, you've got undetectable levels of the good estrogen, estradiol, but your testosterone might be 1800 or 1.8, depending on the units. And before menopause, it can be pretty much the same. So the two things were really understanding that, the estrogen, progesterone, testosterone affect every system in the body, and the testosterone is one of the three female sex hormones. So they're just human hormones. They're not really actually gendered, although they're in different amounts. So yes, so from that point on, I really changed how I practice medicine and realized all the women that I'd misdiagnosed, probably treated with the wrong medications, and it's just been amazing ever since that. And once you see women getting better by having this slightly different approach to medicine, you become a bit evangelical. And so it's probably meant that I've dodged a bullet in terms of professional burnout, because I love my job now. So it's amazing. It's an amazing way to practice medicine, keeping women living their best lives. So so that's kind of where a patient told me to go and upskill. I did go and upskill, and then I've joined the converted.
Well, it's incredible because, all women have obviously hormones, and we go through ups and downs, and we have puberty, and then we have a lot of us will have children, and then there's obviously menopause, perimenopause, menopause. So we've got this kind of, roller coaster in front of us, right? from when we're small. Yeah. And I think that, especially really now, we're seeing people talk about it a little bit more, but it's not really talked about, I don't think, a huge amount. And I think that there's a lot of confusion, right, with women around the hormones, what it means. And I think that certainly when you get to that 40, 45 plus age group, women start thinking, oh my goodness, something's coming, and they start probably looking into it a little bit more. But I think that from my own experience and from talking to an awful lot of women, people aren't prepared for it. And when it happens, they don't know how to help themselves. They don't know what's coming. And I think it's definitely scary, because you can go from feeling everything's great, you've got energy, you're not tired all the time, you're doing stuff, and then suddenly life can change quite dramatically really quickly, right?
Yeah, absolutely. And it is just that we, both as doctors, but also as people, whether you're male or female, we've been taught so little about this. So, our sex education at school is very much don't get pregnant and don't get an STD. And even, education about menstrual health is still very, very, inadequate. So if we sort of move to that place where we educate people of all genders about the impact of these hormones on the body. So understanding the changes that females, people with ovaries, will experience on a monthly basis, then you can start to understand everything that happens throughout your life cycle. So, anybody that has menstruated, without being on the pill knows that your mood is a bit different at different parts of your cycle. And I always, a good comparison would be to say that perimenopause is really the other puberty, at the other bookend of your reproductive years, where hormones, like we know in puberty years and adolescence, hormones don't go in this lovely cycling. They're a bit kind of all over the place because you don't necessarily ovulate effectively every month. And the same thing then happens in perimenopause. You get these wild highs and deep lows, and you might also be running a bit, also lower overall. So, but anybody who has had a cycle knows that you get a bit of a dip in your mood before your period. For some people, it's just that you're slightly irritable or not the top of your game. For other people, it's really serious. And we've got women who get this premenstrual dysphoric disorder where they can feel suicidal for a few days every month. And that happens in probably almost up to, 20% of women. And so I think we all know that these hormones impact us, whether it's our brain or mental health or, our gut health, you would notice gut changes. There's so much more to it than just periods. And then, obviously when when you're pregnant, you feel different and your gut is different and your mood is a bit different. Your skin and your hair are different. And that's all got again to do with, estrogen and progesterone and testosterone and other hormones. And, women, when they've had a baby, they go from these really high levels of hormones to it really plummeting, from hundreds of thousands to like close to zero, especially if you're breastfeeding. You have these really low hormones, and surprise, surprise, women get depressed and anxious and tired. And it's not just that you have a new baby, it's that your brain hormones have plummeted again really over a couple of days. And then you move into perimenopause, and for some people, the same as with pregnancy or puberty, it's not a big deal, but for others it's like, what has happened? I've just been hit by a long distance lorry on the motorway and nobody told me it was coming. So but I think we do have, like, we all have that awareness, but it's never been put into, like an organized structure for women to go, right, okay, so we kind of know, but we kind of don't know. And it's the same with doctors. Like, we know that these things are happening, but I think it's never been sort of just structured to go, well, actually these hormones, we have receptors for these hormones in every single part of our body. So, anything can possibly happen as a result of changing hormone levels, whether that's puberty or pregnancy or being on the contraceptive pill. All the women that say they felt depressed and anxious on the contraceptive pill, that's true, because you're blocking their natural hormones and replacing them with synthetics. Women that get postnatal depression, and then perimenopause and menopause, it kind of makes sense once you go, these hormones impact everything, so but most of us don't know.
Yeah, no, exactly. And that's why, we're talking about it and, today, and that's why I was so excited to talk to you, because it is about education, right? And about us all learning about this stuff, because what I love about what you're doing is that you're treating women for hormones, right? But looking at it from a holistic perspective, because it affects everything, right? And if you're feeling terrible and you're at perimenopause or menopause, or I know you kind of look at hormones a lot earlier as well, it really can be related straight back to hormones. And if you see the right doctor and the right specialist, you can literally change your life, right?
Yeah, absolutely. It is, and it's, I think it's one for a lot of women, it's just understanding why. So having that knowledge is really reassuring, validating, and also just then gives you a framework to work around, and as you say, approaching it very holistically, understanding, the impact of, the things that we all know about in terms of nutrition and exercise or movement and social connection and sleep, and really understanding the importance of those things. And those are the things, alongside hormones, we talk about the pillars of health. That would be your nutrition, exercise, sleeping. I would put breathing in there as well, and social connection and stress management. And then you've got the hormone triangle, and they really interconnect. And the key hormones, in my mind, would be very much estrogen, progesterone, and testosterone. thyroid and cortisol as well. They all impact, but those sex hormones, we are designed to reproduce, so they do probably get the boss, the CEO seats at the table, because that's our primary function, unfortunately. So they are, but they're all connecting and feeding off each other.
And I wanted to talk to you because, certainly over the years, and when I've gone through early menopause when I was 42, and I know some people don't do it till a lot later, and some people are earlier, and so on. But when I started going through my perimenopause stage, I started looking into stuff, and there is some negativity around HRT, but it's different. But HRT has changed dramatically, right, over the past couple of decades. So do you want to talk about that? Because I'm sure there's a lot of women, who are, have heard stories, have read things, and it is a bit confusing, right? Because what hormone therapy is today is very different to the, older school HRT that was probably around 20 years ago or so.
Yeah, no, yeah. So there have been changes, but a lot of the scare around even the older types of HRT is really disproportionate to how safe it is. So in the 80s and 90s, and certainly in the States, and probably similar figures here in Australia and in the UK, about 40% of women were on HRT. And in the 90s, it was largely horses' estrogen, estrogen made from horses' urine, which is actually still quite a safe preparation, but we do prefer to use our estradiol, which is made from yams or soybeans, so plant-based medicine at its best, I would say. So we've replaced that older equine estrogen is a nicer way to describe it, with plant estradiol, and then we used to use synthetic progestins because the natural progesterone is actually quite expensive to make. So it was the main drug that was used back in the 90s was one called medroxyprogesterone, which is used in the injectable contraception, the one where you get an injection every 3 months, which isn't used widely so much now, but it still is used in certain populations because it's very handy, but it's not a great contraceptive. So those were the two. So they had the equine estrogen and this synthetic progestin. And unfortunately, that's when they did the big study on HRT. They started that in 1998, and it was $1 billion study, and it was really going to revolutionize women's health because in the 80s and 90s, it was accepted that HRT made women feel better and also live longer. So they were seeing dramatic reductions in cardiovascular disease and osteoporosis. So they're like, really, we need to do a really big trial so we can use this drug as a preventative drug. If they had chosen to use estradiol and progesterone, which were available at that time, we wouldn't be having these conversations now. But unfortunately, the company, I think the trial possibly had some sponsorship from the equine estrogen, and the synthetic progesterone was cheap. So those are the two that they used. And so the trial was stopped early. And there's a whole story in that in itself, but basically it was a false representation of the findings at that point, and they said it caused breast cancer. Actually, even at that point, the data was not statistically significant, which means it could have occurred by chance, like flipping a coin. But the result, that story got out to the media instantly, like it was kind of planned. I have a whole tinfoil hat conspiracy about that, but it got into the media overnight, and really within a couple of weeks, prescriptions in the US dropped from 40% to 5%, and it's never really come up again. So women and doctors from that point on associate estrogen with breast cancer. So in May this year, they published their long-term findings of that study, because the study did actually continue and with women just on estrogen, so not on the synthetic progestin, and actually came out to show that women on estrogen on its own, so women who have had a hysterectomy who don't need a progestin, had a 23% reduced risk of breast cancer. So, actually the estrogen was protecting women against breast cancer, which is the absolute opposite of what we've all been led to believe. And the human brain is wired to hold on to negative information to protect us from danger. So it's really hard to get anybody, whether they're medical or not, to try and go, really undo that fear and go, no, actually, there's a lot of information, a lot of studies that show that estrogen is very, very safe and perhaps actually protective. But yes, but you're right. The hormones that we use nowadays, we try to use estrogen through the skin. as a gel or a patch, and when you apply estrogen through the skin, so that's transdermal medication, so it gets absorbed into your bloodstream rather than swallowing it and going through your liver. When you do it through the skin, it means it doesn't increase your risk of blood clot or stroke or heart attack, and this natural estrogen isn't associated with any increase in breast cancer either. And then you're using, if you have a uterus, if you have your womb, if you haven't had a hysterectomy, you do need a progestin, and that some women use like a Mirena IUD. But a lot of women prefer to use the natural progesterone because it can help you sleep. And and again, the study data shows that it's not got an increased risk of breast cancer. So we have two really good hormones, and they've got testosterone, which is sort of coming up. You know, we don't have so much data, but it certainly can be a third hormone that can make a difference to some women, although not all women do need to have testosterone added in.
So what kind of women would need testosterone? Because yes, I've heard the estrogen and the progesterone, which you've mentioned that, people talk about, but I've never heard someone saying, oh, you need testosterone as well. So what kind of situations would you need that?
So I suppose it's hard to know when you actually need it as such. So we can, in perimenopause, your hormones are fluctuating. So if you measure a woman who's not actually stopped ovulating yet, if you measure her hormones, the estrogen and progesterone's all over the place. But testosterone is quite steady across the month, and it just slowly declines as you get older. So if you're seeing somebody who's got very low testosterone or lower levels of testosterone, who's also complaining of things like a loss of libido, that can be a person that can respond to testosterone. It's only licensed, and it's only licensed for women in Australia. We're the only country in the world to have a licensed testosterone product, which is pretty cool. But it's only licensed for a condition called hypoactive sexual desire disorder, which is really a long way of saying low desire for sex, or low libido. But a lot of us who work in the menopause space would take issue with that, because libido, if you take the Freud definition, really means a zest for life, for stuff. And it may be that sex is not your thing. You might really like knitting, or you might really like dancing or seeing your friends. So I would see testosterone having this role in mood, in motivation, in energy, which are all really important things for having sex. But they're also important for other things like going to the gym or making good food choices. So most of us who are doing a lot of hormone focused medicine would consider a trial of testosterone for a woman whose testosterone levels were low and who was complaining of problems with brain function. So that brain fog, that wasn't responding to estrogen and progesterone. So just feeling tired. So I do think it has a role for word finding difficulties. So women who struggle with verbal fluency, and talking about the thingamajig and the stuff and the place over and with them. So it can be really good for getting words. But unfortunately, most of the studies, 75% of the studies into testosterone have looked at low libido. So that's where most of our evidence is, because the focus has been on other people using our vaginas. So so that's a shame. But there's some evidence for testosterone and bone density. And certainly you do see women seeming to get stronger and fitter on testosterone. So brain function, libido for life, energy. I think there's probably a role for it in pain. So women who get a lot of joint pain do seem to sometimes respond to testosterone. So it's just, we're all a wee bit different. And this is where it's kind of art meets science, trying to look at the person in front of you. There's not target blood levels. It's like, how is this person feeling? What else is going on? Is it just about hormones? What else is there? And it's never just one thing. It's always a bit of like working out, bringing all the pieces together.
Absolutely. So, Ceri, like one of the things that I know you're passionate about doing is educating doctors, right, and GPs to try and get this knowledge that you now have and your team have to other people, but which is amazing because that's what we need. But if women are listening to this and thinking, well, my experience with my GP wasn't like this, and and they were particularly helpful or knowledgeable on the subject, and they're listening and going, well, this sounds great. I want to try these things, and I want to talk to someone who can help me. What do they do? What's your advice to those people? Because especially if people live regionally, there's maybe not the options. What can women do to go and speak to someone like yourself? And I know you're Sydney on the Northern Beaches, which is fabulous. If you live in the Northern Beaches, you can get in to see you. But if you can't, what can they do?
So I think the first thing is really to get informed. So there's some really good sources of information there. And we don't all agree in the health space. You know, health is very grey. So, and there is a bit of polarization there, which I understand is difficult for women. So it's trying to find information from trusted providers. So certainly I think on social media, there's some really good menopause educators there. There's Dr. Louise Newson, Dr. Mary Claire Haver, Kelly Casperson, Rachel Rubin. So there's a lot of really good people, and you can kind of see them. They're part of the Menopause. So we've got this WhatsApp group of, I think it's about 35 doctors from around the world, you know, so all trying to do our bit to move the dial for women. So on social
Love
media,
it.
there's good people there. There's the Balance website that Louise Newson has developed in the UK, has a lot of really good evidence-based literature and handouts. And we're trying to do the same thing here in Australia and make it Australia specific. We have our website, our menopause education platform has both a clinician facing site to bring clinicians together so they can discuss difficult cases, you know, share information, but also we've got a patient facing site as well, or a public facing site. So for people to come on, look at some of our resources and talk to each other. So first of all, get yourself educated. There's great books there. There's great podcast series there. And once you feel you're thinking, right, okay, I think this might be perimenopause, or I think my symptoms are related to perimenopause or menopause, and I'd like to go and speak to my doctor about whether hormone therapy is appropriate for me. A good thing to do is to download one of the symptom checkers. We've got one on our website. You know, there's ones on other websites, just to sort of bring that in as a kind of, you know, I've done my homework, doctor, and this is what I think. I do think a really helpful thing is, if you're not sure if your doctor's going to be hormone friendly, is to bring an advocate with you. That could be your partner or just your best friend, or, you know, a close friend, because that really shifts the power dynamic in a consultation, you know. So all of us, like I know myself, when I'm a patient, you're quite diminished in the patient's chair. So it is hard to advocate for yourself. I think most people tend to feel a smaller version of themselves when they're in a doctor's room, which is a real shame because it shouldn't be like that. But I think that's a very common human experience. So bring somebody with you who's not going to let you walk out the door with what you didn't want to, what you want, you know, without what you wanted. So having an advocate there. But if your doctor is still not open, you know, you can obviously say, well, would you mind having a look at this, and then maybe I could come back and we could chat again. Or if they're not open to that, asking if there's somebody else in that practice who is more hormone inclined. And if you're still being met with sort of a brick wall, then there are telehealth providers in Australia. One of the best ones would be WellFem, which is run by Dr Kelly Teagle. So she launched that back in 2019, just before COVID, and they're so menopause informed, those doctors there. So the other thing is, you know, there is a big Facebook group in Australia, Menopause and Perimenopause Facebook group. It's got about 40,000 members, and they're very good for signposting people again to a doctor in your area. And that's something we hope to build on our website, is to have a list of doctors that have completed some kind of training that shows that they are skilled and interested in providing this kind of care. Because there are a lot of people out there, but you're right, it's hard to find them, especially for women who are rural or regional, and even harder for women who don't have English as a first language, or, you know, who are relying on somebody else to advocate for them. So yeah, it's
Yeah,
not ideal.
absolutely. It is. It's hard. I mean, I found myself when I was going to the doctor to try and figure out what was going on with me. I think I remember that there wasn't a test per se. I had to have 3 different types of tests, and then after those 3 different types of tests, they said, yes, you know, your hormones have plummeted down to this level, so you can safely say that's what's, you know. But it took time. I had to go for, you know, various different tests at various different places. And I remember thinking at the time, God, if you were, you know, working in a 9 to 5 job and you're extremely busy and weren't able to get away, like it wasn't easy. It wasn't just a quick go in, let's do a take blood and see it. It was a lot of different places to go to get that kind of answer. But when if someone's listening and going, okay, this is me, I am in this stage, but they're not the symptoms aren't diabolical, they're manageable. Would you say that having hormone therapy is still needed for longevity and health, for things like bone density and heart health? Would you advocate for it even if symptoms are manageable, or would you say it all really depends on everyone's individual symptoms?
Yeah, I think it's very much about personal choice. You know, everybody has their own sort of set of health beliefs, and where any type of medication would sit into that. And it's very much about working out what's right for you. But I suppose I would say is that we know from studies that when women take hormones after the point of menopause, so not necessarily in perimenopause, that data is still emerging, is for instance, like if you're doing weight training or resistance training, your muscles will respond better to that if you have estrogen on board. So you will
Right.
get better muscle development. Uh, these hormones are extremely potent in every cell of the body. So there
Mm.
are like certainly the lifestyle interventions, behavior interventions in terms of good nutrition and exercise and sleep, they can mitigate a lot of the health, the adverse health effects of losing the hormones in menopause, but I don't believe that they can entirely mitigate it. So although we're not allowed to prescribe hormone therapy to prevent cardiovascular disease, despite the amount of evidence that shows that if you start hormones around the time of menopause, your risk is dramatically reduced, between 30 and 50% reduction. And if you compare that, for instance, to a statin, might hit 3% in a woman. So we're talking about 10 times the benefit. Um,
Mm.
I think there is quite a lot of literature that supports timely use of hormones, so around that point of menopause in the first few years after menopause to reduce future disease. I do think that evidence is there. We need more, but I think there's quite a lot that's already there. But I think everybody has their own path that they want to walk. Hormones will absolutely not replace bad nutrition, or well, will not make up for bad nutrition or lack of exercise or inadequate sleep or drinking alcohol. So it's not going to be a magic wand, but it allows you to make better choices, to move more, to drink. We see women really cutting back on their alcohol because they're no longer self-medicating with it, and
Yeah,
make
right.
better choices. So I think that we've been scared of the wrong things. We're terrified of estrogen. We should be terrified of alcohol. Alcohol, is a class 1 carcinogen. I see so many women who self-medicate their way through their 40s on alcohol, and we know that increases the risk of breast cancer, bowel cancer, dementia, heart disease, osteoporosis, all of those things, as well as meaning your quality of life's not as good. And so really sort of looking at
Yeah.
choosing the right things
Yeah.
to do, and that's going to be different for everybody. I was going to just go back to what you said about having to do multiple tests when you were in your
Mm.
own early
Yeah.
menopause journey. There are some issues with some of the guidelines for doctors. I think this is important for anybody who's a bit younger, so certainly perimenopause can start maybe up to 10 years before your last menstrual period, and in
Mm.
perimenopause until you're really late in it, so maybe in the last few months before your periods stop, your blood tests will be normal. So irrespective of what age you are, so whether if you're in perimenopause in your 20s or your 30s or your 40s, your bloods will be normal until you have stopped ovulating. So you're not going
Right.
to get abnormal blood tests until really late in the piece. And I think but our guidelines for doctors say check bloods if a woman's under 45, and certainly check the bloods if she's under 40. And that's important to exclude the menopause point, but it tells you nothing about perimenopause. And I
Yeah.
think that's, we have to listen to women. These hormones are safe. I would, the pill is another alternative for women who need contraception. If you finished your family, vasectomy is much better, and using hormones. So, but absolutely, I think there's more and more evidence for hormones as possibly improving women's health span. So we live longer than men, but we live with 4 times the level of chronic debilitating disease once we hit 65. So I do think there's good evidence for hormones reduce weight. It's accepted that it reduces osteoporosis. It's accepted
Mm.
that it reduces heart disease. There's some evidence about neurological disease like dementia and Parkinson's, but that evidence is low. So yeah, I think there's a lot more to see here, and that's
Yeah,
pretty
absolutely.
exciting.
And just talking about, dementia, one of the things in our groups, and we've got, nearly 20,000 women in our groups now. One of the things that people talk about a lot is with menopause and perimenopause too, is forgetting things. And it's from going, I'm doing something, and then literally I've forgotten what it was. And it's a common theme that people talk about. Is that anything to do with that link to dementia you mentioned, or is that something else going on with the menopause mucking up with our brains?
Yeah, we don't have data to show that would necessarily be linked with dementia. Dementia studies are so hard because they require 30 years of prospective data following women up for 30 years, and that nobody's spending that money. because
Yeah.
they don't spend any money on women full stop, but they're not spending that, they're not doing that.
Yeah.
So there's no, you can't say that just because you're forgetting stuff in menopause that you're more likely to get dementia. No, we do not know that to be true. And it probably is not true. We do know that in perimenopause and menopause transition, there's dramatic rewiring going on in the brain. So as estradiol and probably testosterone and testosterone fall, the brain tries to adapt. So in a natural menopause, which is very different if your ovaries are removed or you're suddenly put into menopause with medication, your brain tries to create new receptors, it creates new pathways. So it's trying to work its way around this loss of estrogen. So there is rewiring happening when that forgetting is occurring, which should hopefully get you back to a new stage. But because nobody's actively following women up with really good testing, so a lot of the testing is not quite good enough, not sure whether women just get used to being a bit forgetful,
Probably.
and just suck it up a wee bit like we
Yeah.
tend to do with
Well,
everything.
we do.
So
This is the thing. Women just we're like just suck it up battlers, aren't we? We just keep
yeah,
going.
that's what exactly when you said earlier, like how, if a woman's symptoms are manageable, for me, it's like,
Yeah.
why would you suck it up? But the symptoms we do know that are associated with future risk are hot flushes. So and that's because, and a lot of the focus has been on hot flushes. So everybody knows hot flushes is a menopause symptom. Most people don't appreciate that anxiety and insomnia and loss of words is a menopause symptom. So we all know about hot flushes, and we do know that hot flushes are associated with an increased risk of heart disease and changes in the brain tissue. So our brain does not like those rapid changes in perceived temperature that happens. So when you ask, do you just manage your symptoms, I would say I don't think that our body really likes, certainly we know that it does not like hot flushes.
Yeah.
So there, certainly it's a reason to treat for future health.
Yeah, absolutely. Because I think, as you said, or I said as well, then you agreed, is that women do have a tendency, and I'm guilty of this too, of just going, we're so busy, we have so many things on, and if it's not really bad, we just keep going. And I think that it is important, as you say, if it's doing something negative to the body, don't just suck it up and keep going. Go and get help and do something about it.
Yeah, there's no prizes for martyrs, menopause is absolutely mandatory, but the suffering is entirely optional, so there's nobody
I love
giving you a
that.
gold medal for it,
That's
that's not
interesting.
happening.
Now, a question I've got as well is that over the past, I think it's 12 months probably now, there's been an enormous shortage of HRT or the patches across Australia. And so many people have said that. I was given the patches myself over a year ago, and then they went out of stock, and then I had nothing for 12 months. And it was just, and everyone kept saying, oh, the suppliers. And I know that because one of my friends messaged me last week saying it's back in stock. Is it is that an ongoing issue? And do you know what's, because I was like thinking, God, there must be so many women who have been affected by this issue. But how can it have taken so long to get back in stock? So I was just wondering, do you know anything around that, and if that's going to be an ongoing issue?
Yeah, so I suppose try and start with a praise sandwich and say something positive first. That if you're on patches, then you can use a gel instead, and you absolutely should not go with nothing. A lot of women do prefer patches to gels for different reasons. One, they can absorb a patch better than gel, and it's obviously you only have to change it twice a week rather than put it on every day. But for women who do have symptoms, or certainly who are in early or premature menopause, they absolutely should swap over to another type of estrogen, and that can be a gel, or for a lot of women who are younger, it's safe to change to an oral estrogen, or an estrogen tablet. So the patches, that supply chain, I am not optimistic. The companies that make the natural estrogen patches are big pharmaceutical giants, and their estrogen patch is a very small part of their portfolio, and most of the patches are off patent, so I don't think they make very much money. And we're relying on businesses to provide healthcare solutions for really out of the goodness of their heart, because these patches do not make money, and so I do not anticipate that those companies will prioritize patches. We know that Bayer made the weekly patch that people loved. You only had to change it once a week, and they divested that in 2022. They reduced their budget into female R&D the same year. So I don't think that there is pharmaceutical incentivization to improve that supply chain because there's not money in it. The people that make gel are smaller companies, so they are making a lot of money out of their gel. So they've got a limited number of products. So it is their, it's their priority. It is their priority product. So they will continue to make gel. But there's a huge issue across the spectrum of healthcare, but it's so noticeable in the HRT world. So we're relying on businesses to look after people when obviously their main focus is profit. And so there's a huge disconnect in our system that does not serve people well.
So how does that get fixed? Is that a government thing? Like who do we go to try and fix this long term?
I think there isn't an easy fix. I think you really need a group of female philanthropists to get together and create a manufacturing plant on site in Australia. We haven't developed any particularly new technology for delivering HRT, and I absolutely think there's a lot of potential that we could be doing really clever and interesting things. It's not going to make somebody, well, it could make somebody billions because there's going to be 1 billion women living in menopause by 2025 or 2030 or whatever it is, or there is billions of women, So I think we need to look at a different model. I think traditional pharmaceutical companies, if you look at the amount of diseases that HRT can potentially prevent, if I was a drug company, I wouldn't make HRT.
Really?
Because, well, no, why? If you have 25 drugs that treat 25 conditions and you've got one drug that's quite expensive to make with a low profit margin, why would you choose to make that?
Why can't they just charge more for it if there's enough women who want it? I mean, surely we're not
It
talking
doesn't.
like...
It wouldn't compete with the 2,500,
Right.
150 other high value drugs. Maybe it would, but I think the maths mean that women, that body identical hormones, because you can't patent a hormone. So hormones aren't patentable. So because they're natural.
Yeah. Oh my goodness me.
You can only patent the patch, and the patch is off patent, or the gel. So it's really interesting.
And do you know if it's the same issue with this delivery and patches in the US and the UK too? Is it like a global issue?
It's a global issue, but I think Australia, because of its geographical sort of distance, is always the one that suffers more. Yeah, so very much.
Oh, wowzers, that's scary, I think, because I mean, I know so many women who have been waiting for those patches.
Yes, so I think that could be your next business venture would be to set up on-site manufacturing. There is a demand.
Well, clearly, I know. And for myself, I know you said, the gels and the tablet, but the thing is that I suffer from migraine. I've suffered from migraine all my life. So I have to be really careful with what I have.
Yeah, so you can't have the tablet.
Yeah, and I can't have it. So I'm stuffed. I'm like, I need something.
But you can have the gel, but the gel, it's a bit, There is a third option. Some people, we do have a couple of gynecologists who will put in implants, which sit just in the fat tissue. They're made from compounded, but you're absolutely right. It is, but I do not expect that the government can control the pharmaceutical industry. I think it's the other way around.
Yeah, wow, it's scary, isn't it? It's a really scary thing because you're right, because you can't patent it in something natural, so it's difficult. And the pharmaceuticals do go for money, right? That's what they go for. They go for the
bucks. Business. So. That's fair enough. Yeah. That's okay. Yeah. That's what they are. Yeah.
I know, but we need it.
I know. So there you go, Rhian. You can set that up next week.
Yeah, sure. Thank you. Well, listen, this has been so interesting, and I know so many women will be listening to this and going thank you, because it is confusing, and a lot of doctors aren't equipped with the knowledge that you're equipped with. So I think what you're doing is absolutely fantastic, because we want to be able to talk about it normal and naturally, right? It shouldn't be a taboo subject, and we want to feel informed so that we can make informed decisions for ourselves, and we want to feel good. Like everything I talk about all the time is feeling good. It's not about anything else. It's how you feel. So if you feel bad, that has a huge impact on your mental health, your physical. I mean, it's everything, right? So
100%.
And if we can learn about how we can do this, and obviously natural hormones and hormone therapy are a great way, proven way, managed in the right way to kind of help women feel good again. So I think it's fantastic. So thank you so much for coming on today. It was really good to talk to you, and I'd love to do more with you in the future too.
Oh, thank you very much. It's been lovely speaking to you too.